Hi guys, we're going to try something a little different. I'm going to see if this works a little better. If I can record the PowerPoint slides and then upload them as a video instead of you guys having to download them. I know most of the class has been having issues as far as downloading and listening to the audio. So I do apologize for that, but technology sometimes does not do right. So let's see if we can get this working, and hopefully this will be our solution for the rest of the semester. If not, we will figure out something else to do. Welcome to Chapter 8. As you may know, in Chapter 7, we introduced the newborn and went through their stages of development. Now we will talk about the infant. The infancy is the period between 1 month and 1 year of age. Rapid changes seen during infancy will never be encountered again throughout the lifespan. The infant's physical growth is influenced by genetics, the environment, the ethnic background, and biology. Physical growth patterns include weight, height, and head circumference changes. These will also be noted on the growth charts. Height and weight. Their approximate weight gain is about 1.5 per month or 5 to 7 ounces per week. In the second 6 months, the infant will gain approximately 3 to 5 ounces a week. By 12 months of age, the infant's birth weight will have tripled. Height increases approximately 1 inch per month during the first 6 months, and then about a half an inch per month by 12 months. As far as the head growth goes, the size of the head changes rapidly during infancy. They shouldn't still have that alien head that they did as a newborn. By 12 months, the infant's head will be 2/3 the size of an adult's. As the head grows, the fontanelles will gradually close. The posterior and anterior were discussed as the newborn. Review those. Chest growth. Circumference average is from about 12 to 14 inches, or 1 inch less than the head circumference. By 1 to 2 years of age, the head circumference and chest circumference are approximately equal. When it comes to motor development, this development is strongly related to physical, cognitive, and social development. Voluntary behaviors follow the disappearance of primitive reflexes. To be able to willingly grasp an object, the infant must first lose the involuntary grasp reflex. Gross motor. This is the infant's ability to use large muscle groups to maintain balance and postural control or locomotion. A major task of the infant obtaining postural control is the head control. So they're no longer bobbleheads as they were as newborns. You want to make sure you read the gross motor skills table 8-1 in your text on page 231 to help summarize this for you. As far as the fine motor, this is when the infant begins to utilize the hands and eyes to explore and manipulate their environment. You want to look at the fine motor skills table 8-2, which is also in your text on page 233, to help summarize and categorize this information. When looking at psychosexual development, this type of development is based on the individual's need to seek pleasure. The individual must be able to balance pleasure seeking with societal expectations. Freud's theory of development states that during this stage, the need for pleasure dominates life. Oral stimulation or sucking is the central focus in this stage. Feeding and nutritive sucking becomes the most important source of pleasure and satisfaction for the infant. As development progresses, the infant learns to connect actions with end results. In addition to feeding, Another source of pleasure and satisfaction for the infant is obtained through nutritive and non-nutritive sucking. As far as psychosocial development, this is defined by Erickson. This stage is centered on the concept of trust versus mistrust. Trust is developed when the basic needs of feeding, clothing, and comfort are met by the caretakers. If these needs are not met, the infant will develop a mistrust of others. The quality of the caregiver-infant interaction while providing care also plays a major role. If the caregiver consistently demonstrates nurturing behaviors such as talking, playing, smiling, dressing, and comforting the infant, this will demonstrate a strong sense of trust. If those behaviors are not exhibited, then trust development may be delayed. If placed in alternative child care, the child care provider should be aware of normal patterns such as sleep, eating, routines, cues of when they're frustrated or ill. Confidence in the child's care provider's ability to provide a trusting environment is very important. Just because they're out of the home does not mean that this trust versus mistrust stops. This does not only take place in the home. So if the infant is going out into a alternate child care area, the caregiver there needs to be able to apply that same congruency with what you were doing at home as the caregiver. As far as cognitive development goes, according to Piaget, the infant is in the sensor-motor stage when cognitive knowledge is acquired about an object through interaction with that object and use of the senses. Object permanence, which is where the infant learns an object, is not an extension of the self and continues to exist when it cannot be seen. You want to review in your text 234 and 235, which reinforces the cognitive development as stated in chapter 6 by Piaget. So let's see if we can sort of summarize what the infant should be doing during this stage of development. They should be able to exhibit a real smile, of course, and that happens usually around 2 months. Around 3 months, the infant should be able to smile widely and gurgle when interacting with their caregiver. Separation anxiety may also start in the last few months of infancy. And also around 3 months, the infant will mimic the parent's facial movements, such as sticking out the tongue or clapping, things of that nature. And most importantly, parents may ask you about the head lag by 2 months of age or so. If the caregivers are holding the infant in a ventral suspension position, then he or she should be able to hold their head in the same plane as the rest of their body versus it going forward or backward, whereas you had to support it in their newborn stages. Also, you'll note that your infant may play with toys, such as your 6 or 7 month old. They may like to throw them or swat them across the room, and they find such joy in this, and they may laugh and squeal with delight. This is known as secondary circular reaction, and I believe it's in your book or your text as primary circular reaction and secondary circular reaction. So when a child plays with a toy and they shoo it on the floor, this delights them. This usually does not delight us as the caregiver or the nurse or the care provider. but we usually will pick it back up and put it back in front of the child, and the child does the same thing again, and they think it's so hilarious. That is known as secondary circular reaction. So a lot of the things that we have come in contact with these infants doing, they actually have concrete terms for them. So as we're going through, I will try to provide examples and give you those concrete terms as we come up to them. Also, an example such as your 4-month-old that may be coming in for a well care visit. If they have a delay in development, you really need to know what the milestones are that they should be hitting at that time. Because if you're not familiar with them, then you will never know if they're delayed. So by 4 months, your child should at least be cooing and babbling and trying to put some words together. It might not make any sense, but they'll be like, ah, and, making crazy sounds. Well, what sounds crazy to us makes sense to them. But by 4 months, if the parent is voicing concern that the infant is not babbling or cooing or doing anything in response to them, then they may have a developmental delay or they may have a hearing problem. So you want to make sure you're doing thorough assessments when your infants are coming in. Here we will look at a little health promotion for the infant. The health status of an infant is the major concern for caregivers. They must be aware of the expected physical, emotional, and developmental growth, as I stated in the last slide. They must be aware of these things and the patterns of the infant. Through education, anticipatory guidance, and understanding the family's cultural needs, this can promote optimal health. Health screening. This is usually important since health status is a good indicator of the infant's ability to adapt to rapid changes of growth and development. Optimal health enables the infant to adjust to these changes without placing undue stress on the body. Health screenings begin after birth with APGAR scores and an examination, and within the first year, well child visits should be scheduled when the child or the infant is 2 weeks, then 2, 4, 6, 9, and 12 months of age. The visit usually includes a health assessment from head to toe, a physical exam, growth indicators, and this is when they will plot on the growth chart. They will do height and weight, anticipatory guidance like what to expect from the child during this age, assessment of parental concerns, any concerns that the mom or dad or parental may voice, and administration of immunizations. This is very important. Immunizations, along with the assessment and the growth indicators. Most physicians instruct caregivers to call the doctor for the following reasons. You want to look at the family teaching box on 237 in your textbook. Those are some common times when it is okay to call a physician. Usually they will give you their own sets of rules and regulations on when to call. It just depends on the hospital policy or the facility or that particular pediatrician's policies. Also, with health promotion, parents may want to know when they should wean their child. Of course, if they're breastfeeding, we ask that they breastfeed at least 6 to 12 months continuously. If they can breastfeed for longer, that would be great. But it is important to let the parents know to allow the infant to set the pace for weaning, no matter what age they are. Now, I find it a little excessive if you're breastfeeding and your child is like 3, 4, 5. That's just a little weird to me. And if my thoughts are, if you can ask me for milk from my boob, that it's not okay that you're still on there. So, It may be a cultural thing. I'm not sure. But I know some people that have breastfed their kids till they're like 4. And I just don't understand. But hey, whatever floats their boat, fine by me. But you want the infant to be able to set their pace. That's the point I was trying to make. The infant will not set their pace at age 5, okay? If you're pumping and giving them breast milk to take to school in a lunchbox, maybe a little weird. So, but it also may be a cultural thing. So, I usually just go with the flow of whatever the parents are telling me. As long as it's not hindering the child, it's fine. Okay? Also, if you're assessing the child and the child is not responding to you, it may not be because they have a developmental delay. It may not be because they cannot hear. It may be because they do not speak any English. So, make sure you're talking to these parents or their guardians and finding out what language do they speak in the home. Because although mom may come in or dad may come in and they speak perfect English with you, they may not be speaking any English within the home. So the child or the infant doesn't know any English. Then they're looking at you like, what? Like, I see words coming out of her mouth or his mouth, but I don't understand what they say. So that is part of your assessment. You have to ask, what language do they speak in the home? If you're asking that and they do speak English in the home, then you want to assess if the infant has a hearing problem or, something of that nature. And when you are providing anticipatory guidance, you're educating these parents on what they need to know about their home, about their child, what to expect. And one thing that we really need to educate parents on is home safety. Basically, child-proofing the home for the toddler, because they are on the go. So they will get into any and everything. We want to keep the household cleaners out of reach. We want to keep the gates on the stairs, tumbling down the stairs, and we find them unconscious at the bottom of the stairs. That's no good. We need to put the dog foods away so they're not chomping on that when you're not looking. They're not sticking their hands in the electrical outlets, things of that nature. That is the type of anticipatory guidance you have to provide for this stage in development. Now look at immunizations. Prior to administration, the nurse, of course, must know the contraindications. Immunizations are not usually contraindicated with a mild illness, such as allergic rhinitis, mild diarrhea, or mild respiratory infection are present. As the nurse, you need to provide the caregiver with information about the benefits and risk of the immunizations and answer any questions that they may have. Now, I know a while ago, or I can even say a long time ago, any mild cold or anything like that, they would not administer a vaccination. Some physicians are still in that mindset, so you want to make sure you know what your facility's policies are when it comes to immunizations, because your text says one thing, but real world may say another. So you do want to check on your specific facility or with your specific doctor and see what they recommend as far as giving immunizations and the patient education that is also given. When it comes to vision, the infant's visual system is usually not fully developed at birth. Problems with vision should be detected early in order to prevent delays in development. Visual and auditory abilities have an impact on perception and understanding the surrounding environment. To enhance visual development, a variety of stimuli should be introduced into the infant's life. You want to also look at the family teaching box that is on page 239 in your textbook, which talks about the home care with immunizations. Visual development is demonstrated by the infant's ability to follow a light or object placed within the visual field and the cessation of body movements after fixating on the object. Of course, infants prefer the human face. By 6 months of age, the infants can recognize familiar faces and may experience stranger anxiety. As visual acuity improves, motor skills develop, and the infant begins to respond to a variety of colors and shapes in the environment. By 1 year of age, both near and distant acuities are good, usually within the 20-50 range. Once the skills of reaching and picking up objects have developed, play behavior can be observed to evaluate vision. Since the ability to easily find and pick up small toys is a good indicator of vision in children under 3 years of age. Hearing. The intensity of the infant's response to auditory stimuli may vary depending on the state of alertness. The human voice is an important and readily available sound stimuli, and infants prefer sound of human voice to other sounds in their environment. Hearing problems should be detected early in life, and hearing and vision should be assessed regularly. Usually these will be assessed at birth and then on that cycle when they are going for their well-child visits. Dental care. Tooth eruption and development are affected by genetics, gender, race, and growth patterns. Deciduous teeth are also known as baby teeth. These are the first teeth of the infant. The teething process varies, but usually begins around 3 to 4 months. May be a little irritable when teething. You can give them Ziwiback toast, which is like a hard biscuit that is sweet. I don't know why they would want that versus a teething ring. I think that was something they used back in the olden days because most people use a teething ring now. They just need something to chew on that's cold. That's basically what they like. Do not leave the nipples in infant's mouth while sleeping. This can cause bottled mouth caries or dental caries. Good hygiene usually begins prior to pregnancy, and breastfeeding, of course, is essential. Please do not leave bottles of formula or juice in the crib at night. Fluoride is natural and is instrumental in decreasing dental caries. Children under 12 should not consume fluorinated water. And I'm sorry, that's children under 12 months, not 12 years. And babies under 6 months should not receive any fluoride drops. Most dentists suggest the first visit occur between the eruption of the first tooth and the first birthday. They also recommend that you start brushing the infant's tooth as soon as the first tooth erupts. Now, would you get a toothbrush and toothpaste? Not so much. You can usually brush it with a little baby brush. They even have the ones that fit on your finger, and you can just kind of rub it around in the baby's mouth. They'll probably be gnawing on you because they're getting more teeth, but that is what the recommendations state. The initial dental visit should include discussion with parents regarding how to care for a child or a toddler's mouth, appropriate use of fluoride, oral habits, finger sucking, ways to prevent oral and facial accidents and trauma, teething developmental milestones, and the relationship between diet and oral health. When it comes to teething, this occurs over several months. The periodontal membrane becomes slightly swollen, red, and tender. The infant may have an increased drooling and fussiness. They may have mild anorexia and an increased desire to gnaw or bite on things. They may also have a low-grade fever that has been attributed to teething. If the gums are red and swollen, you can provide, or the caregivers can provide, ice cubes in a washcloth, or that Ziwiback toast that I was talking about, or teething biscuits, or of course a frozen teething toy. Those usually work just fine. Before we move on to nutrition and solid foods, I want to give you a few more examples of developmental milestones for this age group because it spans for the length of 12 months. The infants can do a lot of things and it can get a little confusing as to what age, what they do at what age. So your 8-month-old may be sitting up without support. Your 6-month-old may be rolling over. Your infant may respond to the parents or guardians consistently, especially their voice. Remember that the infant does develop a sense of stranger anxiety. So your 8, 9, 10-month-olds may scream or cry if the parent or guardian leaves the room, and that's just because they can't see you and they think you're gone. Although you're coming back, they think that the caregiver has left. So that is a normal part of growth and development at that age. And that infants will be introduced to foods, which we will talk about in just a minute. But you want to be careful because of the teething and dental caries. So we will move into that at this time. Now, in regards to nutrition, the infant's nutritional requirements are based on the physical activity and rate of growth needed to support life. At 1 month, energy requirements are approximately 110 to 115 kilocalories per kilogram per day. Then that decreases to about 85 to 95 kilocalories per kilo per day. And that's from 6 to 12 months. Fluids usually range from 80 to 50 milligrams per kilo per day during newborn period to 120 to 135 milliliters per kilogram per day by 1 year of age. Solid foods, semi-solid foods can be introduced when the infant is able to sit up well with support. They're able to sit up well with support. Tongue thrusting has decreased and the infant's hunger seems unsatisfied after nursing or a bottle. Usually this occurs between 4 and 6 months. Introduction prior to that can result in food allergies, an overweight infant, and choking. But I want to put an interjection there because some physicians or pediatricians may recommend that you give the infant rice cereal, especially if they have GERD. And we will talk about that later when we go into the gastroesophageal or gastrointestinal disorders, that they do recommend giving a small amount of rice cereal during this time if the infant has GERD. But that's usually the only time. Then they, kind of stick to this 4 to 6 month introduction period. Usually the first food that is introduced will be your iron fortified rice cereal, since it is easy to digest and the least likely to cause allergies. The cereal can be mixed with formula or breast milk and then later on juice or fruit. The nurse should stress the benefit of iron cereal because of infants' great need for iron. Fruits and vegetables are introduced after the cereal. Should introduce veggies before fruits because of the sweetness, of course. And if they get a taste of the fruit, they're most likely not going to want the vegetable. So most fruits and vegetables should be introduced by 8 to 10 months of age. The infant should be able to drink from a cup with help when they can sit up steadily. Finger foods are introduced during the second half of the first year as the finger grasp develops. Nurses should stress the importance of self-feeding as this encourages autonomy. What does that remind you of? What theory of development? This should be making more sense now as we continue to talk about them. The infant need to be given the opportunity to explore the texture, smell, color, and taste of food. So as the parents, we want to educate them to allow the infant to be able to feed themselves, although we are aware that they will be messy still at this time. This does promote autonomy. When we're looking at weaning, the process of giving up one method of feeding for another, usually breastfeeding to a bottle or a cup, this can be hard for the parent and the infant. There's no right or wrong time to wean the infant. Kind of let them set the pace. It can be accomplished with the infants as a guide. If the infant is weaned too soon from breast or formula, iron deficiency anemia may occur. When talking about pacifiers, we know that they are gratified by oral stimulation or sucking. So there's two types of sucking, nutritive and non-nutritive. Enables the infant to obtain nutrients necessary for life through breast or bottle. Your non-nutritive is just a source of pleasure and satisfaction, and it also calms the infant. So this is usually when your pacifiers come into play. And usually this can be given like after a painful procedure or something like that. Should rarely be used after 9 to 12 months, although I see 2 and 3 and 4-year-olds walking around with pacifiers. No comment on that. You should educate your care. Pacifiers should not be used as a substitute for general caregiving, nor as an attempt to meet the needs other than non-nutritive sucking. Many lactation consultants stress the caution to pacifiers due to nipple confusion or refusal. I have yet to find a baby that has had nipple confusion just because they had a pacifier. I just don't see it. But some consultants are avid breastfeeders and they do not want pacifiers at all. So you just have to be aware of your lactation consultants. We call them the breastfeeding Nazis. So that's my little tidbit on that. Let's now talk about communication with the infant. This enables the infant to express needs and emotions and involves the central nervous system maturation, cognitive abilities, and social interaction. Infants' initial means of communication are usually crying and smiling. Even though the infant begins to smile as a reflex by 2 months, the infant has a social smile used to gain attention and amazement from the caregiver. Receptive language is greater than expressive language during infancy. By the end of the first year, the infant can say several words such as dada, mama, bye-bye, and no, no, or stop. They like to say stop too. Once the infant starts to vocalize, the caregiver should repeat these sounds in response to the infant's vocalization. The names of objects or people should be emphasized when talking to the infant. As far as their temperament is concerned, this is the way the child interacts with the surrounding environment. Children are thought to be genetically endowed with specific temperamental characteristics. Do you believe that this is true? These characteristics are behavioral tendencies, not implications of good or bad child. By increasing the caregiver's understanding of the child's personality, or a more effective plan of care can be developed to meet the child's needs. Now we revisit the term colic. Now, often termed infant irritability is one of the most common health problems seen in infants younger than 3 months. This is described as recurrent episodes of unexplained crying and the inability to be consoled. Onset varies, but it usually occurs around 1 to 2 weeks of age and subsides spontaneously by approximately 16 weeks of age. This is characterized by loud, persistent crying and flexing of the hips toward the abdomen. Colic is present if crying occurs during the first 3 months of life, lasting longer than 3 hours a day, occurs more than 3 days in 1 week, and continues for at least 3 weeks. And that is known as the rule of 3. Now, I don't know about you, but if a baby was screaming at the top of their lungs for 3 hours a day, for more than 3 days a week, I think I would go insane. And I see why parents are very stressed about this. Management usually begins with recognizing the problem. Healthcare providers must eliminate any infections or organic causes. Once medical condition has been ruled out, colic should be approached in terms of management. The nurse must assess the daily routines and the infant's normal patterns. The nurse must also work with the family and their emotions. She or he should inform the caregivers not to take it personally, because it's usually not the parent's fault that they're colicky. Parents must remain calm and be encouraged to try breathing techniques and time away from the infant if needed. So sometimes they do need a break. This is not when they would call respite care, though. It's like call a friend, phone a friend, a relative to come watch the baby and let you get out of the house for a few so that you don't lose your mind. That's how that goes. As far as sleep, infants have variable sleep patterns that are influenced by temperament. The transition from neonatal sleeping is a more organized central nervous system maturation after the 3rd month. As the child matures, the sleep-wake cycle evolves into a pattern of being awake during the day and asleep at night. I am sure parents long for this to come. As the infant matures, the amount of REM sleep diminishes and required hours for sleep gradually decrease, and the sleep-wake periods develop into a day and night cycle. This occurs by the time the infant is 3 to 4 months of age. Sleep patterns are usually well established. Infants will also nap during the day. They will take about one or two by the age of 1. After regular sleep patterns develop, the infant will awaken at night, which are known as night wakenings. Night wakenings seem to coincide with the development of separation anxiety. But with that in mind, do not let your child sleep in the bed with you. Once they're there, they never leave. They're like 7 and they're still sleeping in the bed. Not okay. So, you have to teach them that it's okay. You're still there. You'll come in during the middle of the night, put them back to bed, but they're not asleep in the room. Usually, the infant can settle back to sleep if they're left alone during the awakenings that occur every 2 to 4 hours during sleep times. Co-sleeping is common, but like I said, it is often cautioned. I say don't do it. The most important thing, SIDS, or sudden infant death syndrome. This is the sudden unexplained death of an infant between 1 month and 1 year. Most happen between 2 and 4 months of age. You want to teach prevention, which is putting the infant back to sleep and taking all of that stuff that they usually have in the crib out so that the infant doesn't kill themselves. And bathing. Infants do not need much bathing during the first year of life. I don't understand why parents bathe their kids like 2-3 times a day when they don't even leave the house. Baby can't get that messy, I'm just saying. So, they do not need that much water on them. Educate them never to leave the infant alone, even if they're in the little tubs that they've created now for infants. Even in the sink, they can drown. Need to educate the parents on that. And they should not be bathed until after that cord stump falls off. So we tell them, do not bathe the infant until that falls off. Usually that's 1 to 3 weeks. If they are bathing that baby before that cord stump falls off, what can happen? That's when we run into all the issues with the cord stump. They got it wet, it's now infected, it may start bleeding, it's not dry, and that's what it has to be, very dry in order for it to fall off. You also want to educate them to always Do the perineal areas last to decrease the incidence of infection? To prevent cradle cap, which is that dry scalp, they can wash the hair every other day by using that mild Johnson & Johnson baby shampoo or Aveeno or whatever they prefer. If it does occur, the cradle cap does occur, you want to teach the caregivers to use a soft bristle toothbrush to remove the crust and mineral oil or petroleum jelly to soften those patches, and that will usually go away. They don't usually have to be too overly concerned about that. As far as nail and skin care goes, generally the infant does not need a whole lot of lotions or powders. I mean, really, they don't leave the house most of the time, unless they're going right to the pediatrician's office. Still, they don't need all this lotion and powder and all of this other stuff. If lotion is used, it should be hypoallergenic and rubbed into the adult hands first prior to putting it on the infant's body because of cold stress. Baby powder can cause severe aspiration pneumonia, so that is usually why we stress not using that for an infant. Nails can be clipped, although we recommend that they are not. If the parent just insists on clipping the nails, we tell them to do it after the bath because they're usually soft, but we really stress them not to do it and for them to allow the nurse or pediatrician to do it when they go into the office, because they'll end up cutting the infant's skin, and then there's bleeding, and then there's risk for infection, and it goes on and on and on. So we really recommend them not do that. One of the nurses suggested that they use an emery board just to file them down, which I thought was a good idea. So the parents could do that instead of using those clippers. I just do not like them using nail clippers for babies because most of them, like 98% of them, do not have a clue what they're doing. Now, stranger anxiety. This usually emerges around 8 to 12 months of age when the infant develops a sense of object permanence. This usually peaks at about 15 to 18 months and disappears by 2 years of age. Separation anxiety occurs because the infant does not understand that the caregiver will actually return. Characteristics may include overt distress, withdrawing, frowning, whimpering, crying, and clinging. You can briefly read over alternative child care within your text. It pretty much summarizes what is and what needs to be done if taking your infant to an alternative child care area. Same thing as when you were taking your newborn. You want to make sure that they are consistent with what is going on in the home. Lastly, we will look at play and safety promotion and injury prevention for the infant. When we're dealing with play, this enhances the infant's maturation and provides an opportunity to practice newly acquired motor skills as well as learn about the environment and the people around them. It also enhances the bodily gracefulness, promotes social skills, sharpening cognitive and language skills, and extends attention span, persistence, and sense of mastery. By 6 months to a year, the infant will engage in repetitive activities involving voices, sound, music, and a variety of toys, which enhance the development of language and sensor motor skills. To facilitate the infant's continued development, the caregiver should be given information relevant to the toys and activities appropriate for the infant. During screening, a caregiver's description of play behavior can be beneficial in screening for problems such as developmental delays, neurologic problems, delayed social skills, autism, learning disabilities, and emotional disturbances. When it comes to safety promotion and injury prevention for the infant is at risk for accidental injuries. Accidental injuries are the leading causes of death for infants between 6 and 12 months of age. Caregivers must be aware of safety concerns for each stage of motor development, and one way to prevent accidental injury is to, of course, child-proof the home. This now concludes Chapter 8, which went over the growth and development of the infant. After doing Chapter 7 and Chapter 8, you should now have a better understanding of how we will incorporate the many theories that we learned about in Chapter 6 to each stage of growth and development. Take this time to review both Chapter 7 and Chapter 8 for next week's lecture, as we will go over any questions or concerns and do a learning activity within class.